Thank you everyone for joining us today for this webinar. I'm Abby, I'm going to be the moderator of today's webinar. So today, this webinar is going to be on imaging dose to radiotherapy patients and the need for its optimization. And today we're being joined by Dr. Parham Alai to present this information to us. So Dr. Parham Alai is a professor and director of medical physics at the Department of Radiation Oncology, and he's also the director of medical physics graduate program at the University of Minnesota. He has authored and co-authored 44 peer-reviewed publications, 6 book chapters, and has contributed to 70 oral or poster presentations at national and international meetings. He has served as the program director for the 2018 AAPM Summer School, and he has co-edited the Summer School proceedings. He has practiced and taught medical physics for over 20 years and has served on many AAPM committees, including 2 task groups. He's also a member of the Medical Physics Editorial Board and served as the reviewer for many journals in medical physics, radiation oncology, and related fields. During his career, he has taught medical physics to numerous graduate students, medical physics residents, radiation oncology residents, and radiation therapy technology students. And just before I pass you on, I would like to ask that if you have any questions from this presentation, you can just pop them into the chat box and we will get to them at the end of the presentation. And if you want to ask the questions verbally as well, we can unmute the mics at the end as well. But without further ado, I'll pass you on to Dr. Parham Alai, and I hope you all enjoy.
Thank you, Abby, for the introduction. Thanks to BeamHub and Mohammed Jalal for inviting me to this. And of course, we should take note that today is the International Day of Medical Physics. So to all medical physicists out there, happy Medical Physics, International Medical Physics Day. So anyway, the topic of my talk today, as Abby mentioned, is on the imaging dose to radiotherapy patients and the need for its optimization. This has been the topic that I've been working with for the last 15 years or so, and then as the technology evolves and the techniques change, and we have to adapt to the way that we do imaging on the patient with the patient, and then how to account or optimize or measure the imaging dose. So I'm going to touch on all of those in this presentation today. So I have nothing to disclose, and I have pictures related to commercial products that does not imply endorsement of any of them. So outline of my talk, there is a short introduction. I'm going to touch on dose from imaging for diagnosis and simulation, which is not really my area of expertise, but I rely on the colleagues to collect data on that one. And then from there, I move on to the main topic, which is the dose from imaging during radiation therapy that we commonly these days refer to as IGRT. And then there are several topics in that: the dose itself, the inhomogeneity of imaging dose, the peripheral dose from imaging, imaging dose reduction optimization, which is one of the main topics, and then summary and conclusion. So introduction. So again, for radiation therapy, for all of us who've been in the field for a while, we know that obviously we have used imaging at various stages. We use it for portal imaging, we use it for the CT simulation, and so on and so forth, PET imaging, for example. So the imaging dose has traditionally been deemed insignificant because, again, we are treating a patient to 40, 50, 60 gray, so a couple of grays of imaging dose has been deemed insignificant. We've always ignored it in the past. And the sources of imaging dose, as I mentioned, again, diagnostic studies that lead to the diagnosis of the patient for cancer, the CT simulation, possibly more than once, the weekly imaging that we traditionally had done using port films or portal imaging. And again, these are all low magnitude as we compare them to therapeutic doses. So, however, recent trends have increased the imaging dose, hence there's increased attention to it. And CBCT, again, is not new. CBCT was first developed in the late 90s. So it's not that recent. But again, last 2.5 decades, we have increasingly used the cone beam CT and volumetric imaging. And as you know, all the new imaging modalities out there, they all the new Linacs that you get, and many of other non-traditional, non-C-arm Linacs that actually come with the capability of the cone beam imaging. And again, more recently, there has been adaptive planning is basically picking up now, and we are more capable of doing it, whether it's offline or online adaptive. So there is repeat CT imaging, whether it's a Beam CT or maybe actually CT simulation. There's a repeat CT imaging for adaptive planning, which add to the cumulative dose of the patient. So the question is the imaging dose of concern? And the answer is, I don't have a yes or no answer. I say perhaps. For the most part, the magnitude of the imaging dose is negligible, especially, again, as I mentioned, comparing to the therapeutic dose. However, many point to the fact that even a small amounts of additional dose contribute to enhanced risk of secondary cancers. And there are publications out there. There is no definitive answer to this. But again, if you think of the Alara principle, you want to keep the imaging dose as low as possible. And if there are conditions for that, for pediatric cases, it's more important. For pediatric patients and young adults, they live a longer life, right? So again, you want to minimize the dose to them specifically because of the longer life that they would have after the therapy and the chance of the secondary cancers raised. Also, if the frequency of imaging is high or megavoltage imaging is used, there is more of a magnitude of a dose that we should be concerned about. And then the other issue here is the image volume is almost always larger than treated volume. So again, we give it 20, 40, 50 gray to a treated volume, but the image volume is often decided on or determined by the cassette that is being used, the blades for the imaging beam and all that. So the image volume is always larger than the treated volume, and hence more of a healthy tissue, which is not part of the treated volume, is exposed to imaging dose. So this is excess imaging dose to the treated volume and outside the treated volume that we have to look into. So moving on to the dose from imaging for diagnosis and simulation. So again, we don't deal with data therapy physicists, but our diagnostic colleagues, they do deal with this day to day, and there have been efforts to reduce that or set benchmarks for that. Again, so imaging studies leading to diagnosis in part absorb dose to patients. So we know besides the CT simulation, we always have previous CT imaging and there's a PET imaging and all that. They actually contribute to the imaging dose to patient. In medical imaging, the diagnostic reference levels are used to optimize imaging dose. And you may have heard about the DRLs. I have a screenshot from the IAEA page on the DRLs. These are commonly used in the imaging to optimize imaging dose to patients for diagnostic studies. Now, in the therapy, there have been some recent efforts to establish guidelines to optimize, again, CT simulation protocols. And this is probably the first one I'm having here from UK, 2018. Again, they actually survey a dose indices from radiotherapy, treatment planning, computer tomography scans for adult patients. So these are for CT scans for radiation therapy patients specifically, not for diagnosis. And then more recently, there are several papers. This is probably one of the latest ones from 2022, which essentially what they did, they looked at the CT simulation dose from different anatomies. This is a survey done in Croatia, and they came up with these benchmarks, let's say, and they actually proposed a 10 radiotherapy planning reference levels because these are not DRLs anymore. So, and they compared those from the two UK, Ireland, Slovenia, and Finland. And then you can see on this curve here, these are actually the CTDI volumes for head and neck, breast, and so on and so forth. So these are basically benchmarks that can be used if you want to do. You can check your own CT scanner against what's out there, essentially measure CTDI volume if you have access to the phantom, of course, and compare to this. Again, so it's not optimization, but it's again some benchmarking of the CT doses. Now, as I mentioned before, I have borrowed some slides from a diagnostic colleague, Marco Brambilla. And so, again, it's interesting. So can CT protocols used for the, again, treatment planning can be adjusted to optimize image quality and patient dose. So what do we use CT images for CT simulation? We use them for identify the position of the tumor and OAR, so right, for localization. And as importantly is we create a electron density curves, right, for various tissues to be used in the TPS dose calculation. So, and most therapy centers now have access to dedicated CT, so they can actually optimize the scan protocols if they so choose. And radiotherapy CT scanners, often a one-size-fits-all approach is taken. So, I mean, most people do that. We don't, again, we don't pay attention to DRL. We just pick a protocol for head and neck, and we just scan the patient with that one. Now, so this one-size-fits-all approach, there's disadvantages to that. One is that you can, again, there may be inaccuracies in the contouring, for example, but the most important one is automatic KV selection or KV modulation is not used. And we don't use that because if you change a KV, you change your CT density value, so we avoid that. There's some other new advantages out there that we may or may not use. And again, the concern is that if you change the scan parameters, your Hans field values will be different. Again, you introduce errors in those calculations, which is a valid point. And the problem is what level of Hans field unit variation is tolerated for different CT scanners. And there is publications out there. This is one from BJR, and it actually it's a review paper that looks at all different CT scanners and different techniques of how to change the KVP, MAS, and all that, and how it affects the Hans field unit. And then they came up with a summary. And so this is not something that is routinely being done. The KV modulation for sure is not being done. We know the MAS doesn't matter what we do. But we have to keep in mind that if you, to get a 1% dose change limit, the Hans field unit should be within plus minus 20 Hans field unit for tissue, for soft tissue based on IAEA recommendations at plus minus 50 for lung and bone for AAPM. So if is a slight change in the Hans field unit, it probably doesn't make a huge difference in the Hans field units. Again, this what I'm showing here is more of a work in progress. I don't think it's actually being implemented anywhere. Again, in most of the radiotherapy centers, we actually use a one-size-fits-all. So what I'm saying here, we may need to start looking into that and see actually our CT scanner outputs matches that of the others or the diagnostic reference levels from our diagnostic colleagues. So that's all I had on the imaging for diagnosis and simulation. So the bulk of the talk is going to be on the imaging dose from during radiation therapy, again, the IGRT process. So the IGRT that we perform, the imaging dose depends on a number of factors: the beam quality, KV versus MV, frequency of imaging, whether we do planar or volumetric or 2D or 3D imaging, the patient size, and the current and kilovoltage. I mean, if you have a TomoTherapy unit, the pitch matters for helical KV and MV imaging. For cone beam CT, image volumes, arc, start, stop angles, the length of the image volume, and all that matters. And if there are any MV CBCTs left out there, I don't know if there are any left, frankly, in the world or not. But again, the number of MUs and MOs for MV imaging for Siemens scanners, that makes a huge difference. So portal imaging, again, something that we've done since the onset of radiation therapy. And we've always estimated that the dose from portal imaging with a megavoltage beam to be about 1 to 2 centigrade per image, again, using a 6 MV beam. If somebody has access to a 2.5 MV beam, like what is on a newer variant True Beams, that would reduce the dose by half. So I strongly suggest using that if anybody has that on their unit. Actually, the image quality is slightly better too because it's low energy. For KV digital radiography, again, this is oftentimes called KV portal. I'm using the term KV digital radiography, and this is the term that we adapted in TG180. So we won't mix up the KV and the MV portals together. So again, the KV digital radiography has a substantially less dose than megavoltage portal imaging. And so it is, if it can be used, it should be used, frankly. With the caveat that dose to bone is about 2 to 3 times that of soft tissue, but again, still overall is lower dose. And of course, the image quality is improved. Again, depends on the anatomy of the patient. You cannot use it for every patient. And on top of that, the dose drop-off is rapid. So exit dose is substantially less than that from MV portal imaging, which may be beneficial for certain imaging techniques, localizations. The room-mounted 2D imaging, this is the brain lamps and the cyber knives out there. And again, these are 2D images. The dose per image is very low in milligray range, but since we do repeat imaging, it adds up. The primary use of these units is for SPRT and SRS applications. So again, 1 to 5 fractions, so the overall imaging dose doesn't amount to a whole lot on this. And then I mentioned Megavoltage CBCT. Again, they actually have the highest dose if there is any units still out there, especially if the high dose mode is used. And the same thing for Revali and Halsey on 6 MV triple F beam. If there is anybody out there using that actually could be pretty high for the high quality mode. Again, this unit now uses a KV CBCT. And then for TomoTherapy Radixact, again, there is estimates on that. It depends on the pitch, fine pitch, again, more dose, coarse pitch, less dose. So if they're treating a patient, is a long extremity or a spine field or craniospinal, again, the coarse pitch should be used because it's a lot less dose. But if you're treating a brain lesion, for example, then again you have to use a fine one because again you need the resolution for that one. And again, the scan length affects the total dose delivered to patient in case of the TomoTherapy. The newer Tomo units, which is called Radixact now, they do have kilovoltage CT, is called see-through. And the dose from this is, it varies depending on the protocol, but it's comparable to kilovoltage COM-beam CT. So I have some data in here that we collected a couple of years ago. Again, is in the ballpark of the COM-beam CT on like a C-arm LINAC. And then kilovoltage COM-beam CT, which is the bulk of what we use. Again, the dose from that depends heavily on the protocol used. Again, head and neck protocols in general are low dose, thorax are a bit higher, and the pelvis even higher. And the reason for that is because of the kVp use, 100, 110, 120. Actually, low dose ones, some of them use 80 kVp. And the MAS is a wide range of that. So again, depending on the patient size is one thing, and the protocol used, the imaging dose to patient varies quite a bit. And if you want to look at the ballpark figure, like what's the imaging dose out there, and this is what I use if a physician colleague asks me about the imaging dose. Again, this is imaging dose to patient. I should clarify that. Again, MV portal imaging 3 to 4 centigrade per image pair. The newer units use fewer MUs. Digital radiography on a room-mounted KV is much less than 1 centigrade. Megavoltage COM-beam is a high dose. Megavoltage CT is high, relatively speaking, and the kilovoltage CBCT and CT are on the lower end. But again, these are estimates only. They should not be used for any quantitative measures or for addition of dose to patients because a lot of factors affect this. So these are just ballpark figures, just to keep that in mind. And the KV COM-beam CT, again, I highlight that because that's what we use most of the time. So to focus on kilovoltage COM-beam CT, there are a lot of factors that affect the imaging dose or the dose imparted to patient. Again, tube current, the higher MA, the higher the dose, as a linear relationship. Applied voltage, higher kVp is a higher dose, but kVp squared. Multi-filter reduces the dose in general. Start-stop angles on a partial imaging that actually helps with the evading the imaging some of the organs at risk, potentially reducing the dose. The blade setting or cassette size affects the image volume, again, the cranial caudal direction, head to toe. And the patient size, again, the smaller patients receive higher organ dose because, again, this is an example of one size fits all. We apply the same thorax or pelvis protocol to all the patients. So smaller patients, they get higher dose. And again, tube current, this is something we measured like a few years ago. We actually increased the tube current, actually increased MAS, it was total current, and then compared that to the dose measured in phantom. And again, for head and neck, we are somewhere on there. For thorax, trunk is somewhere out there. And then we extrapolated that, we measured it higher. We never use anything up here. But again, the current, as the current is increased, so does the dose. Applied voltage, some measurement, like basic measurements I did, I got about 60% increase going from 100 to 120 kVp. Again, it's in the ballpark of the kVp squared that we have learned from the textbooks. Now, I have a couple of slides on the imaging dose from two units. One is Elekta. This is Elekta XVI on a synergy unit. So I believe the new Elektas have more protocols than what's out here. But this is, again, ballpark going from the fast head and neck all the way down to prostate M10. Again, as you can see, the KVP and the MAS both increase. And these doses were measured essentially with the farmer type ion chamber at the ISO center and then converted to dose. So this is not a patient dose. This is just a measure of the output of the unit in that condition. And as you can see, going from the lowest imaging dose to the highest is a 76-fold increase. So there's a substantial increase in the beam output, essentially, I should say, from what with a change of protocols. The same thing for the Varian, XI, and TrueBeam, again, is a 67-fold increase. So again, this indicates that relatively speaking, obviously pelvis protocol has more dose than an image gently and a head and thorax, and then the pelvis large is very high dose and probably shouldn't be used unless you absolutely need to use that for a large patient. Both high filter, and I think the new units you are pretty much forced to use them. But what it does, again, reduces imaging dose, improves beam quality, of course, too. Reduces imaging dose if the KVP and MAS are kept the same. Intermittent filtration, again, that's not something we can change or affect or do anything about. Again, the newer units have added filtration, which reduces imaging dose. And the arc stop angle affects the dose distribution within the image volume, may affect those two OARs. Again, I have a couple of images on that. And then I talked about blade settings and the cassette size that could affect the imaging volume. Now, patient size. So it's actually some dose calculation we did for pelvis patients undergoing radiation therapy of 25 fractions. And we plotted the dose to organs. These are the different organs. Versus the BMI, body mass index, which is, again, an index explaining the size of the patient. So the higher the BMI, these are actually larger patients, so larger separation. So again, maximum dose is the same because we use the same protocols. Maximum dose is usually on the surface. So, and you can see bladder and rectum and other organs, the absorbed dose to dose decreases. Again, because a larger patient, there is more of the beam is attenuated, doesn't reach the internal organs. The smaller patients, they get higher absorbed dose from the same protocol. And then inhomogeneity of this imaging dose, as you're aware, is not homogeneously distributed. Again, there is varying degrees of inhomogeneity. If you look at the portal imaging, again, this is the anterior and right portal images, 2 MV each. And again, you can see the bulk of the dose is on the right side of the patient, right and anterior side of the patient. Megavoltage CT, this is all the Siemens one. Again, these were fixed gantry and very high dose in the anterior of the patient. Kilovoltage radiography, this is a simulation of the anterior and the right images with, I think it was 110 kVp beam, maybe 120. Again, you can see the rapid dose drop-off. There's almost no dose to the opposite side of the patient from the beam entry point. And the same thing on the sagittal view and coronal view. So again, there is a benefit to using these, that you actually minimize the dose to the opposite side of the image beam. And of course, you can see through these lines, CD and AB is actually going through there, right there. So the line AB is anterior posteriorly, CD is right to left. You can see that enhanced absorption to the bone. This is basically going through the rib cage here. And it shows the enhanced absorption to bone from the KB. So that was KB radiography. This one is the cone beam. Again, Monte Carlo, the same thing. Again, the dose distribution, again, is very inhomogeneous. There is a range of less than 2 centigrade to up to 10 centigrade. It's a thorax protocol. It's a Monte Carlo simulated study. And again, you can see the enhanced absorption in the ribs. And again, those lines correspond to the dashed lines up there. And you can see it peaks and valleys when it goes through the bone. And of course, it's a partial arc. So on this side of the patient is less dose than that side. So KV and MV, we know that, we know the penetration power, we know how they interact, know the penetration power of the MV versus KV is. Again, it's 6 MV versus 110 KV. On this example, again, 6 MV is almost a depth dose curve, and 110, of course, you have the absorption in the bone. And again, this is because of that, because the 6 MV PDD looks like that, and the 120 drops off quickly. So on the exit size, you get a lot less dose from the KV beam. And the peripheral dose of imaging, this is what I talked about image volume being larger than the treated volume. So peripheral dose by definition is the dose outside the treated volume. The sources of that are scattered radiation, leakage, and imaging dose. And it is of interest, again, if it's a electronic device, some organ at risk, previous to treated area near the treated volume, we want to know the peripheral dose is. And again, just an example of that one, this is a 7-field IMRT, and then you treated volume is a yellow color, and then put a cone beam CT on it, and the image volume is going to be this blue line. So treated volume is pelvis, image volume includes the groin area. Another example, head and neck, again, this is a 9-field IMRT, the treated volume is a red box, image volume is the blue box, and again, the treated volume is head and neck, the image volume includes most of the brain and the eyes and optic nerves and all that. So again, the image volume is almost always larger than the treated volume on a C-arm linac because of the fixed blade settings and cassette size. So there has been some measurements of the peripheral dose of imaging. The dose from KV, again, there's 3 studies. There are probably from 2008 to 2012. And again, all 3 of them indicate that the dose from the kilovoltage and megavoltage CBCT are in the same order of magnitude as that from the linac leakage and from IMRT delivery. So again, it's the same. It's not a huge amount, but it's the same. One thing to notice, they add together, right? So now we get the leakage, scatter, and imaging dose on top of each other. Again, low magnitude, but they're additive to each other. So that brings me up to the question. With all the information that we have about imaging dose, the dose to the periphery, dose to the normal tissue, the variation of imaging dose with the technique, is it warranted to reduce the dose burden or not? So it may be warranted. It may be warranted to reduce the dose burden of organs at risk. But perhaps more importantly, it is warranted to reduce the risk of secondary cancer, especially, again, for pediatrics and younger patients. So, again, looking at radiation protection from a radiation protection perspective, from the ALARA principles, it may be warranted to reduce imaging dose if we can do that. The APM Task Group 180 actually talks about this, and it has some techniques for reducing the imaging dose. So these are this is a summary of the recommendations from TG180. So reduce imaging field craniocaudally. Again, you limit the field to what you need. You don't need to image outside the treated volume as much. Portal imaging can reduce the size. For TomoTherapy, again, the pitch is important. For MV CBCT, again, choose lower MU settings or use bony anatomy. And then consider type of imaging. So this is the one I alluded to before. 2D versus 3D. If a 2D imaging is adequate, and if the 2D KV is adequate, that's probably lowest dose. So if it's sufficient, you can use it. If it's sufficient. If it's not, then if you need to have volumetric imaging, you need to do CBCT. So this doesn't mean you avoid doing CBCT. You need to do that if you need that to treat the patient adequately. Again, use the ALARA's guiding principle, and then optimize imaging parameters if you can. Again, there's a caveat to that. You optimize that as long as the image quality is not affected. And I get to that later. And then again, partial rotation KV protocols to avoid critical organs as needed. Beam entry-exit direction to reduce organ dose, especially for KV2D. And the beam filters, this is not something which is in the protocol, but I'm not sure if anybody actually does that, beam filters to acquire planar KV images, but it's out there. Lower dose protocol, a couple of examples. This is a pediatric patient. It was a patient of ours, actually. It's an actual patient undergoing radiation therapy. And again, it was a pelvic treatment. So had we used the default pelvis abdomen protocol, which is this one from Electra Synergy unit, the dose we would have given this patient would have been, I think this is for a number of fractions. I forgot how many fractions, but anyway, it would have been about 40 centigrade, up to 40 centigrade. But we don't use that. We actually use the head and neck protocol for these. So head and neck protocol, again, that's a technique for that one. It gives a dose of about 22 centigrade max. Again, so it's an 18-fold decrease in the dose simply by using a low dose protocol that we have available on the LINAC. And again, this is extremely important for pediatric patients, and image quality is adequate in this case. Another one is a simulated study. Again, this shows the scan length cradiocaudally in head to toe. These are the Electra cassettes, obviously, M, L, and S20. And 20, as you guys know, is basically going in the craniocaudal direction. And if you use the 10 cassettes, you cut down on the extent of the image volume. So you can lower the image volume if warranted, and if your target is such that you can actually adequately see your PTV and your organs at risk. You can actually do that, switch from that to that. Number of projections, again, this was a simulated study. This was on an actual patient, but again, the number of projections can be changed on the protocols. Say go from 900 to 450, and that cuts down the dose by 50%. And again, the dose variation, you can see it here, is a dose reduced by half, just simply by cutting the number of projections. Again, providing the image quality is adequate. Gantry rotation angles. This is a multiple simulated figure. Again, in this case, instead of scanning the patient with the head and neck protocol over the anteriorly, go posteriorly. And that cuts down the dose to the eyes and the lenses, just by simply doing that. Now, those are all good, but is it always a good practice to do that? So is it always good practice to reduce the dose? Oh, the dose is too high, let's bring it down, and we follow ALARA, and it doesn't hurt anybody, bring it down. So yeah, it is a good practice if it does not adversely affect the quality of the image. So image quality is important there. So you reduce the imaging dose, you have to make sure the image quality is adequate. If not, you get a bad image, you get a noisy image, and you have to repeat the imaging. So you defeat the purpose by doing that. So again, your image quality has to be considered if you lower the imaging dose. And again, patient positioning, tumor, OAR visualization, image quality must be adequate. So we cannot just reduce the imaging dose and hope for the best, essentially. So again, imaging dose reduction has been used. I recently changed to using imaging dose optimization, because as I will show you, we don't always reduce the imaging dose. Sometimes you have to increase the imaging dose. So optimization. So this is an example of what we did on a rando phantom. We actually we imaged it with multiple protocols. We gradually reduced the frame per second, or the number of frames, or the MAS, maybe KV on the head and neck, and then we did the auto match feature on the true beam in the LINAC. So this actually we were just checking to make sure the auto match based on bony anatomy works with the lower dose protocol. Again, there is no soft tissue contrast in here, it's a phantom, so just a bone in there. And cutting the frames by 2, and the auto shifts that you click auto shift on the TrueBeam XI, it actually got the same numbers virtually. So again, the dose was reduced by more than 50%, but the auto shift works for bony anatomy matching. And same token, using the thorax phantom, thorax portion of the phantom, again, doing the same study, the milliamp second or current time product was reduced by 2/3. The dose was reduced by 57%, and the auto shifts worked, so it was fine. Again, bony anatomy matching. So bony anatomy matching is fairly easy to implement this. If you want to look at soft tissue contrast, it becomes more tricky and becomes more essentially trickier to figure out what to do and how much we can reduce the dose. And on that, I have a couple of slides from a colleague in UK, Tim Wood, and they actually did this on actual patients. And again, this was a pediatric case, obviously, and what they did, they gradually decreased the imaging technique and the extent of it over several days. And what they came up with was this one. So actually, they reduced the imaging dose by 95%, which is substantial. Again, this is a progression of a dose reduction. Again, it was a bony anatomy matching, and they had adequate images to treat the patient. So again, this can be done. It takes some effort to do that and some work. And then, so again, there's ethical issues in there. If you can do that, the physicians have to be on board. You may have to get approval from your ethics department, your local hospital for embarking in such a project on a patient. Another example from Tim, again, this was a young patient, and then they did over a couple of fractions, and they dropped the KVP from 125 to 110, and the MA from 80 to 40. Again, there was no adverse effects on image quality. The dose was reduced by a factor of 3. So again, this is something that was done by Tim in UK. And this is a reason I mentioned optimization and reduction. So this is actually, it was a poor image quality on a very large patient. In this case, they had to increase the imaging technique. So again, the dose had to be increased, but again, if you have poor image quality, you cannot set up the patient adequately. So again, what do we use the BeamCT for? We use it to position the patient and visualize the internal anatomy. So if our image quality is poor, we cannot do that. So we should, if it comes to it, we do increase the imaging dose. So we optimize that. It's not always one direction. So in summary, radiation therapy patients are exposed to imaging dose at different stages, as we know. Again, it's much less than therapeutic dose. The imaging dose magnitude and distribution is dependent on many, many factors and varies widely within different modalities, different units. Keep that in mind. So there's no number for imaging dose for a patient. There are methods to reduce or optimize imaging dose, but the care must be taken not adversely affect patient treatment outcome. So again, reduced imaging dose decreases the dose burden of the healthy tissues and organs, especially those not in the treated volume. And I emphasize again, this is probably more important for pediatric cases, for younger adults and all that, and it should be considered. But again, care must be taken and not adversely affect patient treatment outcome. And so basically, doing the adverse and repeat imaging and giving more dose to the patient. And thank you very much for your attention. That was my last slide.
And there are no questions in the chat box at the moment, so I don't know if anyone wants to pop any in that they had any. I actually had a question myself based on that. It was really interesting. But what is your opinion on the frequency of imaging? So say like daily imaging or weekly imaging, because that would obviously affect the overall dose.
Right. So yeah. So I didn't touch on that, but there are actually protocols on that. So I can tell you in our own practice, anything which is modulated, VMAT, IMRT, we do daily imaging. The reason being, when you do a modulated treatment, the physician has put I would say, a small margin around the targets, right? So it's very important to treat that right. So we don't want to miss the target. So for those, we actually do daily imaging, daily BeamCT. I know there are protocols out there that institutions employ, and they image the patient, let's say, first week they do every day. And then if there is not a large shift on the second week, they cut down on the frequency of imaging. They do it 3 times or 2 times a week. So there are protocols out there. Again, these are institution specific ones. But if you feel comfortable with the patient, yes, if you feel comfortable the patient is setting up correctly every day, and you can prove that by, let's say, 1 week of imaging, you can cut down on the frequency and do it every other day.
Yeah, that makes sense. Thank you so much.
Sure.
I think someone's typing now, so we'll just give it a few minutes just in case there are any questions coming in.
I have a question myself as well. Thank you for this very, very nice.
I cannot hear you, Mohammed.
You can't hear me?
We can now. Sorry, that was.
Okay, no, yeah.
Okay. Can you hear me now?
Yeah.
Perfect. Okay. Thanks for this very, very informative presentation, Dr. Barham. I have a question myself. Is like, what do you think about the future for the imaging? So, because in the meantime, there are some researches now about the AI and enhanced imaging, like ComBeamCT, and even to use the ComBeamCT as a primary CT, and it's still under research. So, do you think from radiotherapy world, those worlds, is it like justified to invest this amount of time and resources in enhancing the imaging dose if we are going to give like high dose treatment?
So I know there are efforts out there. I mean, especially with adaptive planning, there are new imaging modalities, as you know, that you can actually compute the dose on that, and enhance video units are stable and all that. So that's fine. But from the use of AI, there's some papers out there. I don't do an AI myself, so I don't know where that's going to go. But maybe it can help us in reducing the dose or reducing the frequency, as Anna mentioned, right? But what was the second part of your question? Do you think I didn't catch the second part?
Is it justified to spend this amount of like time and money and to have this reduction of dose if we're going to give the radiotherapy dose at the end of the day?
Well, again, that's a question. Again, as I mentioned, I would probably do it for, as I mentioned before, for pediatric cases. I probably do that, and for smaller patients, I do. I probably wouldn't put a lot of resources into doing it for every single patient. I don't think anybody does that, frankly. We ourselves don't do that. We do it as needed. So so again, we have many other things to do. So
of course, absolutely makes sense.
Right. So.
I have another question. If nobody asking any question for the DRLs, you mentioned that the DRLs for the imaging or the diagnostic images,
right.
But for radiotherapy, like the only one I can find is the one you mentioned in the IBM that was issued in 2018. So do you think it's like would be like a good project to have like national DRLs? It's not diagnostic anymore, like something for the CT or imaging in radiotherapy, at least to compare to, because for example, when we had the CyberKnife in our clinic back in 2013, we were advised by Accuray to scan with very high MA to get image quality or better image quality. So, but there is nothing, no protocol or nothing guiding us to see, okay, we shouldn't exceed this amount of dose for imaging for this therapy or something like that. There is nothing. Do you think
I think it's
a project to have something like that?
Yeah, I think it's a project worth exploring. I showed you that the IPEM paper, of course, and then I showed you that Croatian study. And interestingly, Croatian study compares their results to our Irish one. So I think has been done in Ireland. So it is worth exploring that. Again, that's something. I mean, I haven't looked at that either myself from our CT scanner. I mean, we do have our CT scanner. We measure CTDI volumes and all that, but we don't abide by the guidelines that ACR says for diagnostic one. So I think it's actually worth looking into that. And it's going to be, if you want to do a national study, it's going to be hard, take some work to do. But I think it's worth looking into those and see what we actually doing and whether somebody doesn't use high dose ones. You all remember the issue with the CT scanners back in 2009, 2010, right, in the US, that the MAS was increased substantially. So those CT, you remember the CT ones. So again, the same thing, we don't want that to happen in our field and somebody changes those without us knowing it. So I think we have a holy grip on that one, basically.
Okay.
Yeah, thank you very much. If there's any other questions in the chat box. So if no one else has any questions, I suppose we can sum it up?
If anybody has any questions, you know where to find me, right?
I have one more, if you don't mind.
Of course, yeah.
So, for example, because like most of centers like doing CT protocol for the radiotherapy patients. So, but they don't they have like different protocols for different patient size.
Right.
Like if we are going to scan a prostate, for example, we are going to see to use a CT pelvis.
Yeah.
But do you think it might make sense to have a different protocols for different patient size, or this might increase the error during the scanning?
Right. I mean, it probably makes sense to have it if it's rolled out carefully. Again, we don't want to, as you mentioned, the error. We don't want the CT tech to pick up a low dose protocol for a large patient, and then they have to repeat the imaging, right?
Yeah.
The purpose. So that's the issue. And yeah, most centers don't have anything in diagnose. In imaging, they use the KV modulation and all that to overcome that issue, which you cannot do the KVP modulation, of course.
Yeah.
But yeah, that's worth exploring. If one is doing it, I would go slowly. I would pick a couple of protocols. I wouldn't go to more than that.
Yeah. Thank you very much.
Absolutely. Okay.
Thank you so much. That was so interesting, and I think everyone took something from that. So,
Okay, I hope so. Thank you very much. Thanks for the invitation again. Nice to meet you all online.
Okay.
Thank you.
Thanks.
Bye.